Hi there. I'm Dr. Gay Carlson, president of the American Academy of Child and Adolescent Psychiatry, with number 31 of my Screenside chats for our AACAP members. As you know, my goal of the chats is to share timely clinical practice and other important information from experts on key topics during the COVID-19 pandemic. Reminiscent of President Roosevelt's fireside chats during the Great Depression and World War II, I've wanted the topics to be informative, relevant, and interesting. I'm really pleased to have Dr. John Walkup with me today. Dr. Walkup is chair of the Pritzker Department of Psychiatry and Behavioral Health, the Margaret C. Osterman Professor of Psychiatry and Behavioral Science at the Ann and Robert H. Lurie Children's Hospital of Chicago, and Northwestern University Feinberg School of Medicine. Many of you know John as someone who's able to translate complex information into lectures which have earned him most requested speaker at our AACAP meetings. John is best known for his talks and research on Tourette syndrome and other tic disorders, and on anxiety disorders, where he's been instrumental in developing and evaluating psychopharmacologic and psychosocial treatments. He's done other things, but those are the ones that you've known him the best for. I asked Dr. Walkup to talk with us today about school refusal. We're going to be starting school in September, and school refusal is going to be a big issue with many of our kids. Over the past 50 years, there's been a dramatic change in our understanding of school refusal, but our treatments haven't changed all that much over time. We have medication, psychotherapy, and behavioral interventions that focus on what the school refusal has meant in that particular family. COVID-19 has only added another layer of complexity. I know in my own practice, we have two groups of kids that I see. There are the acute school refusers, and then the kids that have been school refusing for many years, and COVID-19 just put the final nail in their proverbial coffin. So, Dr. Walkup, tell us a little bit about the history of school refusal and how that's going to help us manage these kids.
You know, Gay, when people talk about school refusal, I go back to our friend Rochelle Klein's study from 1970-71, where she probably did the first comparative effectiveness trial of psychotherapy and medication. She had four groups: kids with psychotherapy plus active meds, psychotherapy plus placebo, and psychotherapy alone and med alone. And what was interesting from that study is you could get kids to go back to school with behavioral therapy, but they didn't feel very good. And you could get kids to feel better with medicine, but you couldn't necessarily get them back to school. And what she found in the combined group is that you could get kids feeling better, but you could also get them back to school. And so I think we may have come a long way from that study in 1970-71. But in reality, using and thinking about combined treatment for the underlying condition, which I think in that study was really separation anxiety, using combined treatment is probably still the best process to move forward and get these kids back to school.
So there are a number of things, at least that I've found, that have been associated with school refusal. Separation anxiety and school phobia, social phobia are the two key ones. The kids that are self-conscious because everybody's going to be talking about them and they don't know what to say, and the separation anxiety ones. But you know, one of the things that I've found is many of the kids have learning disabilities and language disorders. Their families have learning disabilities and language disorders. So my thinking has often been that you need a push to school from the families and a pull to school from the schools. And I don't know whether that fits into your trifecta there or your bifecta of meds and psychotherapy. But I really think that there's also a collaboration that's necessary in terms of getting the kids out the door, but also getting the kids pulled in. Is that something that's only, in my sort of specialty school related practice, or do you get that too?
Yeah, I think, when I think about kids who are school refusing today, they really need a full kind of diagnostic assessment to understand really what are those things that are getting in the way. And I agree with you. I think traditionally it's been separation anxiety, But, we see kids with generalized worry who underperform academically and begin to kind of see school as a failure experience. We see teenagers with social phobia who begin to stop going to school in adolescence simply because they're so uncomfortable. We see kids with ADHD and learning difficulties where the match between the school and the kids' capacities are so poor that they just see no value in going to school. So, and we see kids with depression who have depressive episodes during their adolescent period, and they fall out of school for a period of time. And it's extremely difficult for them to get back on the horse again and get back into school. So looking for that primary condition is really, really important. The second part for me is really looking at kids' temperament. Are these kids who are kind of plucky and tough? Do they have grit? And are they going to bounce back from some of these conditions? Or are these the kinds of kids who, under the pressure of these conditions, really have a hard time mobilizing resources? And I think the thing that I've really noticed over the past maybe 10 years is that families are much more willing for kids to not go to school. Mm-hmm. And so, when you and I were going to school, we went to school. It was like almost probably the threat of parental whatever making us go to school. But, parents nowadays are really uncomfortable. And more recently, post-COVID-19, parents are really uncomfortable sending their kids back to school. And I think the other thing is that we've had some trouble within our school systems, such that parents really don't trust schools anymore. So they kind of are making decisions to not even provide support for kids for kind of a basic education. So I think we have now layer upon layer in trying to kind of disentangle what's going on with a kid who doesn't go to school.
Yeah. Well, so that's been my experience, that it wasn't that it was easy to get them back to school with medication and behavioral treatment and so forth. It was that, you at least had everybody pulling the ship in the same direction. Now we don't have that. And part of the issue is, in my experience, sometimes the parents had learning disabilities. They didn't finish high school. They have to go to work. I mean, the family I saw the other day, the parent is getting up at 4:00 in the morning to get on the road to go to New York City for the job. And so there's nobody there to get the kid out of bed. And so you've got a kid who's got a long history of not going to school. And really, they're not going to say, "Oh, good, I'm going to get myself to school today." And so those are the ones. So I don't know. Do you have any thoughts about how you manage that? We have a system problem here, and you and I were talking before the interview about what you're facing in terms of collaborative care. It seems to me that we've got somewhat similar issues as far as school is concerned. That we need a kind of a collaborative care model there.
Yeah, I mean, when I talk to teachers, many again, for kids with separation anxiety, teachers and counselors kind of people up in the fall because they know there's going to be a whole bunch of grade school kids are going to have trouble getting out of the bus or getting out of the car and kind of making their way into the classroom. But the new environment really is not just about that kind of grade school age kid. It's really across the whole age spectrum. And I really do believe that there is kind of much more support from families for kids not attending school. And so while we would traditionally do psychotherapy with the child or behavioral work with the parents, a lot of what I'm doing now is talking with parents about the importance of actually going to school. We actually have to convince parents that school is a meaningful activity for kids, and that they really need to kind of overcome their concerns and worries about sending their kid to school and get back on track.
When we were talking at the top of this interview, when we were talking about meds and psychotherapy, maybe you could go through your list of what medications you like to try as far as managing the kids are concerned from that end, and also if there are particular approaches you use psychotherapeutically.
Yeah, I think, the SSRIs are probably our best bet for separation anxiety, generalized worry, and social anxiety. And, if you think about from psychotherapeutic points of view, exposure-based treatments, particularly for separation anxiety, where you can use desensitization techniques to get kids to kind of repeatedly get closer to approaching school and getting inside. Kids with generalized worry are much more difficult to use exposure-based kind of treatments simply because most of the worry and concern is inside their head. It isn't really specific avoidance issues, although you can do desensitization with those kids too. And social anxiety takes, I think, a little extra effort in part because the social aspects of social anxiety require sometimes group treatment for these kids to really become effective at moving forward. But, we're seeing another trend in the literature, and that is moving much more towards family-based treatment. So Eli Leibovitz has a treatment called SPACE that that really is a totally family focus, getting parents to decrease accommodation. And I think what's cool about that treatment is that really crosses disorders. So it will address accommodation in the anxiety disorders with ADHD, with your learning disorder group population, with depression, and get families really mobilized to be much more effective. So it's a cool treatment and something slightly different than maybe what we've been thinking about historically as therapy.
Can you, this is news to me. Can you say a little bit more about it?
Yeah, so he did this very cool study comparing individual CBT versus, never seeing the kid, working with the family only, and it equally effective. And certainly we know in this group of kids who are school refusers, there's a huge family component. Mm-hmm. And it's really, really important to get those families mobilized. And what he did is he kind of took it to the max and decided that he's just really going to do family-based only and see how far he can get. And he got a long ways just working with the family.
So this is working with resistance or overcoming their anxiety, or when you say working with a family, and just one family at a time, or family group approach?
I think it's mostly an individual family focus, but if you think about it, there are these reinforcing patterns that kind of keep it all alive. So, kids who are uncomfortable refuse school because it makes them comfortable. So they're actually internally rewarded for their refusal. And when they do that, they get a lot of positive attention about their distress from their families. And their families begin to say, listen, it's just too tough to deal with you, so we're just going to let you stay home. So they facilitate that avoidance. And so I think what happens in this treatment is he focuses on those aspects. One, getting kids to begin to take on the challenge of going to school. He works with parents to not reinforce impairment, but to reinforce kind of pluck and grit, if you will, to get kids back on track again. And then instead of kind of facilitating avoidance behavior, it's about how to take a step back and then get parents to provide support for kids re-engaging in those kinds of activities. All of which are the kind of big behavioral interventions that you do to reduce accommodation.
Mm-hmm. And how long does this take?
Oh, it's a kind of a classic psychotherapy. It's a couple of months of sessions. Uh-huh. I think most of our treatments are in the kind of 10 to 12 weeks kind of thing. He's in that ballpark.
Yeah. So it's not an overnight miracle, but to some extent, it's, what's the little joke about how many psychiatrists does it take to change a light bulb? And the answer is one, but the light bulb has to want to change. I think that to some extent, you need to have a family that is motivated to change, or that recognizes that there's something here that's a problem. And because it takes some effort, and it takes getting over the parent worry. And again, I had a family the other day where nobody was vaccinated, and he wasn't even anti-vaxxers or any of the rest of it. It was like everybody's anxious, and so this one is anxious and that one's anxious, and so they end up reinforcing each other. And I think that's what happens as far as the school refusal is concerned, that the kid is worried that he's going to bomb at school, and not bomb the school, but not do well at school. And the parents are saying, well, and he has stomach aches, and the teacher said a mean thing to him in fourth grade, and he's now in 11th grade. Teacher said a mean thing in fourth grade, and he's never recovered for it. And so there's a whole story that goes on in the family that kind of justifies that approach, and it takes some work to kind of chip at that.
Yeah, I think for me, the hardest one to tackle is when the families and kids on some level have a higher order value system that essentially says, I really don't need school. School is not important in my course and development. And where they are actually value driven not to attend school. Because then what you're talking with those families about is not kind of overcoming anxiety or worry, or getting more comfortable kind of facing challenges, but it's really about changing worldview.
Mhm.
And I think increasingly we're seeing families that really believe that our educational system is in serious trouble and they really don't want to expose their kids to some of the problems that are at school, and they wear it as a badge of honor. So those families for me are the most challenging.
Mm. You mentioned something about group before. That's something that I keep saying to our outpatient director. We ought to have groups for school refusers. I mean, there in my experience, there are a lot of middle school students that have a lot in common, and they may in fact get support from each other. Are there are there group interventions for kids like this?
Well, the problem with school refusals is they don't even want to come to therapy, let alone come to
But
a
we can
group.
Zoom now. We can Zoom
Oh,
it.
okay.
Yeah, they don't even have to you know, get themselves in there physically. It just seemed to me that that was of all of the things that might lend itself to a telehealth approach, because I think the kids want to have a social relationship. They want to have friends. They want to have some support. They can't get themselves to school to do it. And I just didn't know whether, because I'm not somebody that hears a lot about that kind of treatment. I wondered if there were groups out there, but I gather you're not hearing about it either.
Yeah, I don't. Again, the numbers of these kids. It's not like we have 50 of them at a given time and kind of run 5 groups of 10 kids, kind of thing. We'll have 3 or 4 kids at a time. Our partial program does a lot of work with these kids. Some of
Mhm.
these kids, in order to break the cycle, spend a little bit of time in an inpatient unit,
Mhm.
and then we begin to kind of do some kind of increase exposures during the time that they're in the inpatient unit and kind of get over the hump, if you will.
Mhm.
So in those programs, it's all kind of group or milieu based, and so we use them there. But we don't really have enough of these kids within an outpatient department to begin to put together a kind of a cohesive group, if you will.
Right.
Plus, I see school refusal as kind of a psychiatric emergency, particularly for the acute school refusers.
Mhm.
And the idea that you might wait for a group to start in a month or something like that, I tend to think about individual care as really the kind of focus. Individual and family care is the focus. And at some point, particularly for the socially phobic, anxious teenagers who may have a long chronic history, I can see group therapy for a group of those kids working together to kind of overcome that and kind of create new patterns, particularly for that adolescent group, because they're going to have to think about leaving home and launching soon. And so I can see a whole value to group therapy for that adolescent population.
Yeah, that's actually the group that I was thinking of, because like you, we used to be able to use our inpatient unit as a way to get them used to first going to school in the hospital and then going to school from the hospital, and then golly, you're going to laugh at this, but we used to be able to send the kids home overnight and have them get on the bus in the morning. I'm afraid managed care put an end to that because they figured, well, if the kid was well enough to go home and stay overnight, they didn't need to be in the hospital anymore. We managed to keep a lot of kids out of the hospital with that approach that we can't do when they fail, but we can't do it. So, there are other, I guess, approaches that we could use, but it does seem to me that this would be a school-wide thing where different schools might be able to get together. And I don't know, it's just my thinking about it would be for the adolescents, it might be a good experience having a peer group of kids where they could support each other going to school rather than staying home and being in their shells. Um,
That sounds like a great idea to me. A school-based program
yeah,
for kids that are kind of have been identified as really struggling.
right.
Yeah, I can see that but I'm not aware of school systems that do that. I'm sure there are some,
Yeah,
but I'm not aware of that group.
right. Well, I'm not
You
either.
and I come from a similar generation. And before I went to medical school, I worked on an inpatient unit. I remember having separation anxiety kids in our unit and then discharging them and then going to their house and picking them up and taking them to school to kind of make that transition as a milieu tech, if you will. I did that kind of work in the bad old days.
Well, I think it was a very effective thing to do. Well, we're not going to change that overnight. But in terms of the, as I was saying before, to me, that would be a school-based intervention that would be worth trying to promote, especially to the adolescents. Another school-based intervention that, I don't know, maybe schools would run screaming into the night about is the kids that I see have a long pattern of poor school attendance. First grade, they were absent 10 times. Second grade, they were absent 15 times. Third grade, they were absent 20 times. Fourth grade, they were, it's like, do you see a pattern here of, oh, well, they had the flu. Oh, their left side bothered them. Oh, they had. And so it seems to me that there ought to be a computer program that says when this child in elementary school has 3 consecutive years of more than 5 days of being absent from school, and they don't have some, really recurrent serious illness, we need to nip that in the bud. We need to get those kids taken care of in elementary school, because they're the ones that when they get into middle school become much more difficult to treat. What do you think about that approach?
Well, I think that's a great idea, but I think our schools historically have had a lot of trouble with kids who are invisible or withdrawn or isolated. It's much easier for schools to worry about the kids with disruptive behavior disorders than the kids who don't show up or the kids who are really quiet or withdrawn. And so I think, we've actually written about isolated withdrawn behavior and how predictive it is of poor outcomes. But I think it's very difficult to get school systems to worry about kids who don't show. It's one less kid in the classroom. They're more worried oftentimes about getting through the day. But I agree with you. If there was really some overarching kind of positive behavioral health program within a school that looked at both kids who are disruptive as well as those kids who are isolated and withdrawn and kind of really not engaging. Speaking of engaging, just talked with Cheryl King about risk for suicide. And one of the things that she's found in her recent study is that school engagement is probably one of the more powerful protective factors. And I think when we think about some of our kids, our adolescents who are at risk for suicide and anxiety disorders, and particularly those kids who are not engaged in peer groups due to anxiety or engaged in school due to anxiety, those kids run a somewhat higher risk of suicide. And she actually found that thinking about school engagement for those kids might be a really good intervention to prevent suicide.
Well, okay. I think we need all the help we can get, certainly with the suicide piece. We've been talking before, as far as the med piece is concerned. For a long time, one of the interventions that we used, or that I used, would be you get the kid over the hump with a benzo and hope that the SSRI is able to sort of pick up the slack and continue to get the child de-anxiefied so that they can get to school. Is that an intervention you use anymore, using benzos?
Yeah, again, not for the chronic. Mm-hmm. For the kids who are chronic, they really have those 4 layers of kind of reinforcement that kind of keep them out of school and that make it difficult for them to get over the hump. But for that really acute onset, there are some kids where you just want to get them back in school as fast as you possibly can. And a low dose of a benzodiazepine while you're waiting for the SSRI to kick in is probably not a bad idea. The problem is those medicines work so well at kind of reducing that acute moment of anxiety that sometimes I find it hard to get rid of it once the SSRI is on board and kids are doing better. The families really see it as he's nervous. Let's take the pill. It works really well to decrease anxiety very acutely. And it's hard sometimes to get people to come off.
So it sounds like you need to pick an exit strategy before you even start and say, this is a temporary measure, and it's a it's the stitches until you heal, but at some point we have to cut the stitches, or I don't know, some kind of metaphor, so that that part of it is taken care of.
Yep.
Any other medication tricks that you found helpful in terms of managing these kids?
Well, for the truly extremely young and extremely anxious kids who essentially almost seem to lose reality testing
Mm-hmm.
when they're falling apart with fear and worry, sometimes a little low dose antipsychotic works with those kids too, to kind of, it provides anxiety relief, but it also provides some capacity to stay organized when they're flooded with fear and worry. Again, that's a short-term strategy, and I don't like to use it, but sometimes, again, if you really are in that emergent situation where an acute school refusal, sometimes a little antipsychotic really helps the kid and family fall asleep at night and get up and get going in the morning, and with better organization and better capacity.
Yeah, that sleep piece that's a whole other topic, but I think that's another piece that makes school more difficult for kids in middle school and then in high school, is the progressively earlier time of getting up, and their anxiety keeps them awake at night, and so they can't get up in the morning, and so then we're late for school, and then it's embarrassing to get to school, and it's another one where you really would like to have a system change of having later school for teenagers than what we've got.
Yeah.
Well, we have our work cut out for us, John. I think in terms of managing getting kids back to school and handling their anxiety, I think there'll be no shortage of business for you.
There's never been a shortage of business. We actually began to do college refusal. If you think about the extension of this problem, we developed a program in New York for that transitional age youth that really has trouble transitioning out of the home and into the work world or staying at college. And so, our early experience with the 7, 8, 9-year-olds really began to translate into the 16 to 26-year-olds who are having problems transitioning into adulthood. Many of the issues are exactly the same. They just have a different developmental feel to them.
Well, let's end on that note, because that's kind of a fun thing to think about, is the importance of development in terms of what it is we do. And as we both know, children are not small adults. I think it's more likely that adults are big children. So anyway, thank you very much for being with us. Good luck with the rest of your what's on your agenda for the day. And I thank the audience for tuning in. And we'll see you in a couple of weeks.
Yeah, thanks, Gay.
Thank you all very much for tuning in. This is Gay Carlson for AACAP's Screenside Chats.
Provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.